Okay, so there are lots of great questions. We won't be able to get to all of them, and I've combined several of them. So Amanda, I'm going to start with you. There's several questions about how to improve handwriting, endurance with handwriting, the function of handwriting when people have EDS.
Yeah, great question. So a few different strategies. Again, everybody's hands can be a little bit different. Some things to consider. Sometimes I mentioned that slant board earlier. You can actually take like a binder, not a floppy one, maybe more of like a cardboard or one of those harder plastic. Turn it around so the slope is sloping down towards you. That allows, again, a little bit more of a slanted, elevated surface. That puts your body and your posture in a little bit of a better position if you're somebody who maybe has neck pain, shoulder pain, instability there. When it comes to the hand endurance and hand weakness, it could be seeing a therapist for some specific exercises for strengthening the hand, but it also could be a matter of using a different tool. Can we get a larger pen? If you search for an arthritis pen, can make it a little bit bigger. Maybe I get a lot of different feedback. Some people like chocolate, some people like sorbet. So some people like ballpoint, some people like felt, some people like pencils. It could be finding the right type of pen or tool that works for you, but can we wrap the grip or get some kind of a way to make it bigger and fatter so it fits easier in your hand? But I would try, or again, bracing. You've got a beautiful silver ring on your thumb. Maybe it's, again, collaborating with an OT or a therapist to see, do we need to stabilize at some of those joints so you can protect them, so you can get a little bit, that can tie in with the muscle power too, because if you're hyperextending a lot of those digits, that's going to lead to fatigability of your hand too. So it could be a combination of trying some of those things.
Excellent, thank you so much.
Yeah.
Dr. Ericson, there's several questions related to tendon injuries and rotator cuffs. So how successful is surgery for a torn labrum, biceps tendon? Do you have any recommendations for people about cautions of certain surgeries that are likely to be more or less successful in the shoulder?
Well, shoulder surgery is a little bit unpredictable in EDS patients for a couple of reasons. First of all, the tissues tend to be crappy. And the second thing is that a lot of patients, even though they're hypermobile, tend to make a huge amount of scar tissue. And if you're operating the shoulder and tightening things, it may seem like you're right in the spectrum where you'd like to be in terms of stabilizing things in the operating room, but post-op, it turns to cement. And it's best to seek treatment with someone who's a knowledgeable provider and actually listening to people. And my colleagues as a group, I think, tend to, if the patient is known to have EDS, they may not even get an appointment. That sometimes the secretaries are trained to tell patients with EDS not to bother coming in because the surgery fails. So I have a hard time, convincing my colleagues to operate on some of these patients where the success rate at 5 years might be 70%, and they don't want that 30% failure rate, but the 70% that succeed are really happy. So it takes finding a shoulder surgeon with big balls to address these issues. And the medical care system is being dumbed down on a daily basis, which makes this more of a problem. So you make an appointment to see a doctor and you see a PA instead, and the PA orders MRI, and the MRI might be normal, and the shoulder might be grossly unstable. I do think a dynamic stabilization program is the best thing to do, and also start with scapular stabilization, because the rotator cuff muscles get weak when the scapula protracts. So I would exhaust all physical therapy methods before considering surgery. But the labral tears, if you're in the more 1/3 of women spectrum than vascular EDS, the surgery works pretty well if you can find a provider.
Excellent, thank you so much. A question that I'll start with and then Amanda can take over. So somebody asked how to treat loose wrist that's been loose for 20 years, immobilizing it completely for a time. hasn't worked, and PT strengthening hasn't worked. And I think it's important to know what stage in the recovery process you're at. So an immobilization splint is good for decreasing inflammation in the acute phase, for protecting it in the subacute phase. But then to make the ligaments stronger, you need to be exercising, and the goal is to be doing the right exercises. So if strengthening didn't work, maybe they weren't the best exercises, or maybe you didn't have good proprioception to begin with. But after the acute and subacute phases, you want to be trying to not use the splint unless you're doing stressful, strenuous things with your wrist. Be doing those proprioception exercises, gradually progressing, strengthening. Ligaments are very, 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 very slow to recover. Even 2 years after an injury, they only recover about 80%. And so the muscles have to be particularly good at doing the job, and then maybe using adaptive technology to protect your wrist from those strenuous things, avoiding things like hands-on wrists that are just really difficult. Other suggestions, Amanda?
Yeah, 100%. I would, not to say question what exercises they were doing, but were they appropriate exercises and were they graded to their level? Because when it comes to tissue healing, there does need to be a little bit of that challenge. It needs to be challenged so then it can regrow. But if we over challenge it and your tissue can be a little bit more fragile being hypermobile, we could be going right back to square one versus elevating it. So I would start low and slow. It's better to start maybe with like some isometrics or something that's not going to cause a lot of movement. You always want to make sure you're staying within a good level of pain threshold, but it could be meeting back with the therapist. And totally agree with the bracing. Again, I like to keep it functional. If there's an activity you know that's going to be aggravating for your wrist that you have to do, put that on there, but you want to make sure that you're taking it off and giving your wrist that freedom to move as well.
Excellent. Thank you very much. Dr. Ericson, another question for you, and I certainly hear this a lot from patients as well. After shoulder surgery, sometimes the physical therapy exercises seem to overstretch the tissues. And of course, we know that if the PT is not trained in treating hypermobility, they may not appreciate how fragile the shoulders are. Do you have any recommendations for your patients when you tell them, okay, yes, physical therapy is important, but what cautions do you give them for physical therapy related to shoulder surgeries?
Well, I'm a hand surgeon, so fortunately, I don't operate on the shoulders, so I don't have to deal with that kind of risk. But the shoulder is particularly tricky to get a good result because the tissues react unpredictably to the surgery. That you soak these tissues in blood and they become thicker and tighter. And it can be a life-changing event to have good shoulder surgery. If you're in the vascular EDS category, sort of the extremely hypermobile, the surgery is unpredictable. But if you're more in the one sort of women category with just generalized laxity, if you can find a provider who's knowledgeable, they can guide you through this reliably. I would like to say two things. The handwriting thing is related to the proximal median nerve issue. And if patients don't respond to what you've described, the anterior interosseous nerve is the cause of this and can be fixed surgically and doesn't really respond to anything else. And it responds immediately and permanently in the recovery room. And the surgery itself is not painful. You have to understand some obscure physics and anatomy to figure this out. And my views are completely contradictory to my colleagues who believe what they read. And this nerve problem is described incorrectly. And to demonstrate the weakness, you have to understand the Blix curve, which has to do with tension from contraction versus tension from stretch. So it's kind of a complicated topic. So I don't think I think the handwriting thing is really just a nerve problem, and patients can spend years in therapy trying to make it better. But when the nerve doesn't work right, these two muscles don't work right in any EDS patient. And the weakness is painless and people adapt to it. And you can use the next muscle down, which is a different nerve, or you can pinch sideways using ligament resistance, or sideways using ligament resistance, or pull the wrist up. And patients don't get they don't consciously pick which way they adapt. And some of it has to do with Monday morning versus Friday afternoon, and some of it has to do with the size of the person's hand and the ratio of the length of the thumb to the index finger. So it's a complicated topic. And the other thing is the wrist instability. There are types of wrist instability. One is called dissociative, where the scapholunate ligament tears and you get static changes on an x-ray. And another type of instability is non-dissociative, where the ligament between the radius and the capitate stretches and you get instability between the rows of bones. So the, I don't know if I can show this to you. This ligament in Ehlers-Danlos patients, let's see if I can get the camera to, there we go. This ligament in Ehlers-Danlos patients is stretchy, and if you fall, it stretches more. And what happens is you get the same mechanical effect as if the ligament is torn completely. And patients who fail what you've described in terms of trying to strengthen this respond dramatically to surgery. And it's an operation, like in my case, I've done 3,000 of with up to 17-year follow-up. But as far as I know, my partner and I are the only providers in Washington State diagnosing and treating this particular problem. And the complaints and exam are identical to patients with a torn ligament, but the X-ray and MRI are normal. So patients have exactly what you described, and if therapy makes them worse, sometimes they get blamed by the doctor for not, doing what are they doing wrong, when the joint is mechanically unstable, as if the ligament is torn. And the scar forming that can be a hazard with the short shoulder actually really benefits the wrist. So you can open the wrist up and remove the inflamed tissue in a way that makes the ligament thicken and tighten, like prolotherapy. So we actually take a blunt instrument and sort of stick it in the ligament and move it around without cutting the fibers. And when blood soaks in there, the ligaments thicken and tighten. And it's a very reliable operation. But it's a little weird being a provider with 3,000 cases and
Dr. Ericson, can I ask you to wrap that up, because we do have a number of other questions as well. Sounds like we need to clone you.
I'm trying to get this out there. So there is a chapter in that book, Symptomatic, that describes my partner and my approach to this, which is describes the most coherent problem description and treatment without getting to surgical specifics.
Okay, thank you so much. Lots of information there. Another question for Amanda. A lot of people spend a lot of time on keyboards and using mice as part of their job, and they really can't avoid that. Any recommendations or adaptations for the keyboard or the mice for people who spend a lot of time on their computer?
Yeah, 100%. So we always want to make sure when we're looking at our workstation, zoom out a little bit, because sometimes while the issues are a little bit more distal, like I talked about at the mouse and at our keyboard, let's look at what type of chair are we in? Is it supportive enough for our upper body where we can rest those elbows and reach the keyboard easily? You never want to have to reach forward for your keyboard, so making sure it's close. There are various types of keyboards that exist out there. Everybody's body's a little bit different. There's something called a split keyboard, where it's almost like they took a keyboard and they cracked it. So it's kind of like in half. The idea is that it's in a little bit more of a natural positioning for your arms. So some people find benefit from that. If you search for an ergonomic keyboard, sometimes it's got a little bit more of a mound shape. So it's a little bit bigger and again, easier for your fingers to reach. Keyboards that are flatter, and then again, just checking like how much pressure do we have to give to press the buttons could be something to consider. Definitely making sure that your wrists are in this like karate chop neutral type positioning when you're going to type. But some people also find benefit. I took an ergonomics class before where sometimes having more of like a negative tilt. So having again, adjusting our station, making sure we're changing position every 20 to 30 minutes, checking in, opening and closing the hands, micro breaks, 10 to 20 seconds, just to get some circulation, some blood flow, re-get those brain cells back to what we're doing. Again, tilting it. It's okay to have it in an extended position for a little bit. Again, we just don't want to hyperextend or lean into those end ranges. But a negative positioning might be helpful for a little bit. Neutral positioning, cocking it back, just not too much. When it comes to the mouse, I have a lot of patients that really enjoy and like more of a horizontal type of mouse. A lot of our mice are the classic ones, your palms are straight down. You don't always know when you're overreaching, and it can promote you doing a lot more of that windshield wiper type of motion with your wrist, and a lot of people can have a lot of like wrist pain, small side, that ulnar side of that wrist. But when you have more of a horizontal mouse, it cues you to use more of your arm, and you're using a little bit less gravity when you're clicking and scrolling. So I would try some of those tools.
And you might also consider trying some dictation tools
500%.
and see if you can do some tasks, maybe your emails, things that are a little bit less urgent where a typo would be a problem, and try typing less if you can.
Yeah, Dragon Dictation is a good tool for dictation, and Microsoft Office actually has dictation built into it for free if you want to try that out as a starter.
Excellent, thank you. A question about, or responding to my discussion of weight on extended wrist during exercise being a problem for the wrist, participant says this explains why bird dogs and fire hydrants cause severe pain and instability in my wrist. What are some good alternatives that activate this same muscle? And you want to, fire hydrants can activate different muscles. So I really loved Aiko Callahan's presentation yesterday where she said, whatever activity you want to do, figure out what are your challenges and what do you want to get out of it. So if you want to get hip abduction from your fire hydrants, you might be able to lie on your bed or your couch and lift your leg out to the side. And so you could strengthen your hip. You won't get core strengthening. So if you want core strengthening, you would need to modify it in a different way. You might be able to do something on planks or planks on top of yoga blocks. So the type of modification will depend on what it is you're doing the exercise for, because there are lots of different options, but try shifting the force to different joints. Any suggestions?
Yeah, no, I actually recently found there are these yoga blocks that they make for wrist pain where they've got a little bit of like a foamy cutout for you to put your hands on there. And I know you mentioned that during your presentation, like, can we use a handle or hold on to a dumbbell? A lot of times dumbbells, personally, I don't have a lot of fat on my hands, so it presses in. So they make ones that are foamier and softer to hold you in a more neutral position. So might be changing the position, coming to the forearms, doing it from a wall, again, doing it from a softer support to promote that more neutral positioning.
Excellent, thank you very much. Another question for Dr. Ericson. If we can be brief and take a couple more questions. A couple of people have asked if you've had 2 surgeries and it hasn't fixed the problem, is a 3rd surgery a good idea? Obviously that'll depend on what the surgery was, who did it, et cetera. But are there any general guidelines that you can offer people?
Is the 3rd time the charm?
I would go to someone who has the most experience in training in the area. So, for example, when you pinch the median nerve at the elbow, it causes carpal tunnel symptoms. That's not carpal tunnel syndrome. It's the same nerve. So when you pinch the median nerve at one location or the other location, you get symptoms where the nerve ends. So a typical story would be, median nerve symptoms assumed in a 6-minute evaluation to be carpal tunnel syndrome. And then, non-operative measures fail, so they get surgery. And the patient said that didn't work. And the doctor says, yes, it did. And then the patient keeps complaining of wrist pain with pronation, like typing or using a mouse. And the doctor thinks it's, quote, severe tendonitis or recurrent carpal tunnel. So they get a second operation of the carpal tunnel. And that didn't work. And the patient says, that didn't work. And the doctor says, yes, it did. And assumes the patient seeking drugs or disability or is disgruntled, when it's the same nerve pinched at the elbow. And the median nerve at the elbow is a problem for 100% of EDS patients in my experience. And my hypothesis is that these patients have soft nerves with tight muscles. And there's a lot of collagen in nerves. And if the collagen is abnormal, the nerve tensile.
So it sounds like you're saying if the doctor sees a different problem that hasn't been addressed, it might be well worth it.
Absolutely. So people get misdiagnosed. The median nerve problem of the elbow causes referred pain in the wrist. And this gets misdiagnosed as severe tendonitis or carpal tunnel in a wimpy patient or FCR tendonitis or de Quervain's. And they get operated on where the symptoms are, but not the cause. And
I'm sorry, Dr. Erickson, I'm going to ask you to pause. There's one question that's come up several times, and I'm going to ask Amanda. Pulling on compression garments. Really hard for the fingers and hands. Suggestions.
Yeah, great question. I get this one a lot. There's a lot of different devices that exist out there. I've seen some people are able to finagle like a sock aid to help. There are some, depending on the type of compression that you need, but I have had some patients have good luck. There are some compression stockings that have a zipper down the side. And so you can slide it on a little bit easier and then zip it up. I would just recommend, is there a way we can rig a bigger zipper pull onto there? It's gonna depend on the grade of compression that you need. And I know that there's different tips and tricks with like using a plastic bag to help, but do you have anything on that too?
And rolling them up and then unrolling them, or getting 2 sets of compression at 20 millimeters and doubling them, because the 20s are easier to put on. You double them, you get 40.
And they slide easier on each other.
Correct.
And not right after the shower.
And
The other thing is if you use these three fingers, like these don't work right. So it's hard to
so
pinch and
using the pinky finger, yep.
use these three fingers, which
For
are
sure.
ulnar, and pull up. And there are also devices that will hold the stockings apart and sort of push your foot into it, and then use these fingers to pull the sock
Excellent
up.
suggestion. So we are out of time. We will try to answer some of the other questions online. Thank you all so much for coming. I do believe it's break time. It's break time. Thank you, Dr. Ericson. Thank you,
Thank you.
Amanda. Nice to meet you.
Nice to meet you.